now let's focus on frontline options and second-line options. If you want, based on subgroup analysis or analyzing the studies and your experience, how you will strategize the treatments in frontline and second line, and I can give my opinion later on as well.
Yeah, this is the question of the day. So, of course, we're at an academic institution. We are always hoping to advance the field further and have a variety of clinical trials that are our priority. But in patients not on clinical trials, right now we now have in the U.S. approved sorafenib as well as lenvatinib. And while the overall survival outcome for lenvatinib was non-inferior, there are some distinctions between the drugs, both in the secondary efficacy endpoints, with lenvatinib having a higher response rate both on investigator and central review by EMRASIST as well as RECIST, and longer time to event, with my caveat always that it was an open label study, so those are a little harder to interpret, but nonetheless longer. But conversely, there are also tolerability and toxicity differences between the drugs to balance in this decision in our inherent organ dysfunction population. So with those thoughts in mind, when I have a first-line patient and considering sorafenib or lenvatinib as a standard first-line therapy, one thought which comes to mind right now is my top deciding factor is what is their liver function, because we do have a substantial, at least from not only my own practice experience to date, but also the experience of sorafenib, we have more data in hepatic dysfunction and organ dysfunction populations from the CLGB 60301 trial and from the original phase 2 trial, which included almost a third of patients with Child-Pugh B. We have more experience dosing the drug in Child-Pugh B or worse hepatic I should say in Child-Pugh B hepatic dysfunction, not worse, but in patients with more compromised liver function. And so if I'm not certain about their liver function, I will generally prefer sorafenib right now, because we can monitor very closely and know how to adjust the dose, potentially empirically starting with a lower dose if needed and escalating is my current practice actually. Conversely, the lenvatinib response rate does incline one to think about a patient with a more bulky or large tumor that would benefit from shrinkage, either from perspective of relieving pain or other impending obstruction or other complications from a bulky tumor. A higher shrinkage rate potentially might guide one towards lenvatinib. And then I think within those considerations, there are also the differences in toxicity where, a patient with pre-existing diarrhea, for example, one may be more inclined to use sorafenib, or a patient who gets early hand-foot syndrome on sorafenib, one might want to switch to lenvatinib because it has a lower rate of hand-foot. But those are the things I think about.
Yeah.
So.
Also, I think that data we have after thorough analysis of sorafenib throughout years is that it works very well in hepatitis C related HCC. Certainly the hazard rate is close to 0.5, so it's a very strong data. It comes from multivariate analysis of meta-analysis of the two main trials, and I think that this is quite strong to suggest that certainly for hepatitis C related HCC, probably sorafenib may be the choice. Eventually, in the subgroup analysis of lenvatinib, certainly it shows up that with hepatitis B virus, lenvatinib works pretty well. So eventually this also maybe another point to take into account in the decision making.
For systemic therapies, we had for a long time only one option, which was sorafenib, and we used it for many years as the standard of care in first-line therapy. And there were a couple of trials that investigated whether we can use other TKIs or combination of drugs to improve the outcome for patients in first-line therapy. But all of these trials failed. And only recently the REFLECT trial was reported, which basically evaluated the efficacy of lenvatinib compared to sorafenib in first-line therapy. This was a non-inferiority study, which was positive, and with this we have basically evidence to use a second drug, lenvatinib, in first-line HCC. The question which drug would be the preferred drug, I think it's still open, and we have to see how we can really use lenvatinib in real-life practice. Based on the data we have seen in the clinical trial, there's no benefit or significant benefit in overall survival. However, when we look at the secondary endpoint like PFS, TTP, response rate, we have good evidence that lenvatinib is a drug which might be more effective against the tumor compared to sorafenib. But nevertheless, this did not really translate it directly into a longer overall survival. Therefore, I think we have two options, two drugs, and we in the future, in real life setting, we will get the feeling which drug might be the best drug for which patient.
Currently, we have a frontline systemic therapy, two options. One is sorafenib, another is lenvatinib. Actually, lenvatinib was approved last year worldwide, and the reflex study showed non-inferiority, but anti-tumor effect is superior. In lenvatinib, like response rate is 40.6% and 10% in sorafenib. So response rate is better and PFS better. So in Japan, 19% of frontline agent is lenvatinib now. So all over the world, maybe lenvatinib is gradually become a first choice of option. Of course, sorafenib is still a frontline agent.